And I'm really excited to tell you about my lab's work on diagnostics for point-of-care monitoring, specifically in this case for antiretroviral drugs. Um, and I'll give you a bit of sort of what I'm going to talk about. In some ways, actually, this is the least microfluidics talk I could give you, but that's kind of by design, because I think both for the trainees, but I think also for all of the people in our field, I think a lot of this work has challenged how I approach my diagnostics and microfluidic expertise, and has made me think a lot about how deeply I engage with collaborators and clinicians and people that are really close to the problem and people who live in many of the situations that we claim that our technology is trying to address, and has helped me see where my expertise is useful. So it's really challenged me to not be a plumber with tools, but somebody that really meaningfully tries to solve problems. Um, I want to first thank my lab, our collaborators, and our funders, and everybody who makes this work possible, because it's sort of the classic, if you want to go fast, go alone. If you want to go far, go together. None of this work would be possible without all of these people and many more people who are not on here. Um, and I also want to sort of give you the microfluidics nod, right? Because this is a microTAStic seminar series. So I put a couple slides on microfluidics because how could I not? A lot of my career development and progression really took place because I came up in David Yunker's lab. So I trained with David Yunker at McGill. That's where I did my PhD. I'd done my master's and my undergrad at the University of Alberta in Edmonton, where I worked with Chris Backhouse and Linda Pilarski there, who were trying to make a little microfluidic tricorder toolkit using sort of Matthews-style valves for peristaltic pumping. And one of the things that happened when I moved to David Yunker's lab was we said, what if we went entirely with surface tension, sort of capillary force driven flow, with the idea being that we want to get rid of instrumentation completely to make things more amenable to point of care testing. And around the time I joined the lab, Bruce Safavier, who was a PhD student at the time, he now runs a company called Sensorial that tries to commercialize some of these technologies. And David had come up with this idea of capillarics and sort of designing capillary-driven microfluidics like electric circuits. Most fluids and microfluidics people are fairly familiar with the hydraulic electric analogy. And what David and Rusbe were looking to do was saying, can we take individual capillaric fluidic elements and assemble them together in this way, where you have very, very clearly defined equations. You have these analogies between perhaps channels and wires, wicking capillary pumps, and batteries and fluidic resistances that are very programmable to control timing and flow rates. I'll just give one example of capillarics, but this is the analogy I'm kind of playing at, of capillarics perhaps being a way for us to go through from old school cell phones. And I guess I'm now old enough to remember back when sort of these satellite phones were all the rage and you had to carry something around. And now we all carry these phones that have more power than we used to send people to the moon, right? So the idea is, could we do something like this for microfluidics and make them truly point of care? And the other layer of this analogy that I really like is that once we get to that point where the technology is truly deployable, but also powerful and flexible and capable, then you can start to build application interfaces on top of it, where the technology in some sense becomes boring, and what you do with it and what a non-expert does with it becomes what's interesting. So one example I like to give is these retention burst valves. This is a still image, and I'm going to explain how these work. The idea is that you essentially have a fluidic tug of war where you have different microchannels, and you can calculate the capillary pressure of your channels, these wettable channels, using sort of the Young-Laplace equation. And you see that the height and the width of the channels are on the denominator here, meaning that are inversely proportional to the capillary pressure. And so that means that your largest channel has the lowest capillary pressure. And the analogy I like to give here is that this is my 2-year-old, very loud, but kind of small, and they don't really have that much energy. And I would very easily win in a tug of war with my 2-year-old, I like to think, contrary to his belief. The slightly smaller channel here is like my 8-year-old niece. And she would definitely beat my 2-year-old in the tug of war. And then you could sort of scale this with my now 13-year-old niece. And then I like to think that I would win in a tug of war with all three of them, even if we're connected at the same time. However, I am not so strong that I could even consider rivaling, the WNBA MVP, Adria Wilson. So if you set up your capillary pressures in these very carefully designed way so that you get very tuned pressures, the net result is something like this, where you can load liquids. I skimmed over this, but there's a fluid element called trigger valves that can stop your liquids. And then your tug of war kicks in, where you get this very clean, very crisp sequential delivery of multiple liquids. In this case, we're showing this with 4 different liquids. The devices here were 3D printed and then replicated into PDMS molds. Since then, David's lab and many others just directly 3D print these capillary microfluidics. You can stop liquid, you can release liquid. So this was one example of these capillaric elements where there's like 4 or 5 different elements that are essential to get this very carefully graded, pre-programmed autonomous liquid delivery. We moved on from that and we said, why fight? Why have this tug of war where like you have to make sure you find very, very carefully spread people? What if somebody had twins. How do you get that sequential delivery in that scenario? And so we moved to this concept of domino valves that we later sort of called microfluidic chain reactions, with the idea being that you can get this very scalable, very pre-programmed control. And if any of you has fallen down like a YouTube or internet rabbit hole of just looking at like really cool domino shows, the things you can do with dominoes are ridiculously impressive. And so one example that we did in this scenario is basically we designed these devices where you could preload multiple liquids. And then once you click things into place, then you can automate like an 8-step immunoassay with wash steps. So in this case, the yellow represents the sample, the blue represents a washing buffer. But this is doing what you would be doing in a lab context, whether by hand or with a liquid handling robot, and getting the ability to add in wash steps, but with the convenience of doing this outside a lab or without um, a sophisticated liquid handling robot. So we did this with 8 liquids. This is work that Mohammed Yafi and Oriel Imber, who were postdocs that were hired in David's lab shortly after I left the lab, and they both moved on to bigger and better things now. We've also even done this and shown that we can do sort of 300 liquid delivery steps because now this technology is inherently scalable, and it's this idea of sort of dominoes falling after the other. And on the right here, I kept these equations here because we still keep in mind sort of channel dimensions, surface chemistry, liquid properties. So this is a lot of the microfluidics, and that's the world I came from. And I finished my PhD, and then I came to Seattle for a postdoc. And when I came to Seattle, I was faced with a completely different prospect. And this was the case study that was put forward to me. The case study was, you're a clinical provider, you're a healthcare provider, say a doctor, say a nurse, you have somebody come in, and they tell you, hey, look, I'm still having symptoms. You gave me medications that were supposed to work. I'm still having symptoms. And you're sitting there and you've read your case studies and your clinical trials, and you're like, these medications should work unless you're not taking them. So you're like, are you taking your meds? And the person says, yes, every single day. And then you're in this really weird situation where like the most likely reason for the medication to not work is something they're telling you isn't happening. And it creates this adversarial relationship between the healthcare provider and the person receiving treatment, right? So I came in and I had clinicians say to me, could you, within this doctor-patient visit, measure medication levels accurately and tell me something that's clinically actionable and meaningful? So that's where I started. And we started working on that in 2018. And then I went to my first HIV conference in 2019. And I had the opposite experience. I'd never been to a conference where there were patient advocates there. And the patient advocates were like, there are also studies that show that when you train doctors and clinicians to have really delicate conversations about medication adherence and you record them having those conversations, it often comes across as accusatory and policing and not actually helpful, and it leads people to disengage with care. And imagine you're taking all your meds, but it could be something else. Perhaps you're pregnant, perhaps you're having drug-drug interactions, and the only thing people ever ask you is if you take your meds. How would that make you feel? So even from the patient point of view, or even from the person seeking care point of view, they want tools that will allow them to take control and ownership of their health because they often care about how they are doing and the health of their loved ones just as much and perhaps arguably much more than the clinical providers that they're seeing. So there's this big, big need here. And so when I came into the space, some of the things we tried to figure out were like, I'll give you a quick crash course on HIV, the same way I got it. HIV affects a lot of people. This map shows sort of the global distribution from our world in data. This is as of 2021. You might see this sort of hotspot in sub-Saharan Africa and places that are not high and middle income countries. The main message I want to give on this slide is that the median in this distribution is not the message, because if you zoomed in, for example, on the US, which is where I live, and in the US, if you highlight the HIV population, but you also superimpose perhaps poverty indices, right? You actually find that HIV tends to disproportionately affect people who are somehow already disadvantaged or marginalized in society. So this can also include men who have sex with men, people who use drugs, sex workers. So HIV is one of these diseases where there's this double whammy of socioeconomic behavioral issues on top of a health issue. This is another map that kind of highlights that. So it talks about number of new cases. I'll move on slightly to sort of the virology of HIV, because in many ways it's actually a very, very cool virus. It sucks because it has this huge public health impact, but virologically it's very, very cool. HIV isn't really what kills people. What kills people is this progression to acquired immunodeficiency syndrome, where the HIV virus takes out immune cells, CD4 immune cells, and then leaves you open to opportunistic infections like tuberculosis, cryptococcal meningitis, tumors, et cetera, et cetera. Good news is we have very effective medications, like I talked about. So we have antiretroviral therapy that can basically reduce HIV virus down to levels that we cannot detect with any available tests. And there's this mantra of undetectable equals untransmittable. And this is the part where I will usually ask people, if this was an in-person lecture, if anyone knows a very famous public figure, at least in the US context or sort of the sporting context, who's been living with HIV for a very, very long time. If you know the answer, feel free to put it in the chat. Because we don't have that much time, I'm just going to reveal it. It's Magic Johnson, and in many ways, he looks and lives arguably more a healthier life now than at any point in his life. But you don't have to be Magic Johnson to live well with HIV. Access to antiretroviral therapy has increased dramatically worldwide. There are now over 25 million people receiving antiretroviral therapy. We've seen stark decreases in number of new infections. There's been significant decreases in number of HIV-related deaths. All good news. We can even give people preemptively antiretroviral medication as prevention so that if they're exposed to HIV, they do not get infected. There's also post-exposure prophylaxis, where if people did accidentally or potentially were exposed to HIV, you can give the medication shortly after to prevent infections. This is all wonderful news. But these are the clinical studies that those clinicians look at, right? Where they do meta-analysis of HIV prevention trials. And actually how people figured this out was they did a number of trials to prevent HIV, and some of them worked, some of them didn't. And then they plotted their data where the x-axis is how many people in those studies had just detectable drug levels. They didn't even say, was the drug level good enough? Just, did they have any drug in their system? And then how effective was that study at preventing HIV? And there was this very strong correlation, which feels very intuitive. If you take your medications, they will work. This is another part where I often ask people, because we're very quick to apologize. Well, just take your medications. Separate from all the socioeconomic sort of stigma issues, access issues related to this, there are even really simple things that many of us know that we ought to do that we don't do, right? Like, for example, if you're having some sort of like physical discomfort or pain, we might be prescribed physical therapy. How many of us do that? Or even simpler, how many of us flossed today, despite our many recommendations from dentists, right? So there are many things that we know we ought to do that we don't do. And part of the goal is sort of how do we support people as they try to do many of these things. Um, Another sort of thing that's come out of these studies is we now actually have very, very good thresholds for what dosages roughly per week correlate with complete HIV prevention when people are on PrEP or HIV prevention, and what dosages essentially are like you're not taking HIV medications. And these have come from clinical trials. They've also done directly observed therapy studies, and they even have like these automated pill bottles. So we have very good information about what drug levels correlate with which outcomes. And we have that information not just for preventing HIV, but for treating HIV. So for example, if you look on the x-axis here, this is just drug level. Y-axis is how many people showed up to their care visit and had undetectable virus. And you can see as you have more drug, the number of people with undetectable virus increases. As you have less drug, the number of people with undetectable virus drops dramatically. So we know that drug levels matter, and we have very clear thresholds and very clear targets. So in many ways, it's actually a really good diagnostic problem for us. The World Health Organization has this sort of flow chart that tells you what you're supposed to do when you're monitoring somebody for HIV. You do routine viral load monitoring. I won't go through the whole thing, but I'll skip a little bit and just kind of focus on this part. If somebody comes in and they have a detectable viral load, one of the things that people often recommend is they say we need to give them enhanced adherence counseling. And that's where you get these really like weird conversations. So in this context, you do enhanced adherence counseling, and then you come back 3 months later, and if the same thing happens, you enhance adherence counseling and come back again 3 months later. So we need better tools and better ways to intervene in the middle. And many people are starting to think that drug level feedback can allow you to quantify adherence and not just have these adherence conversations, but provide it as a tool to people to help make their lives better. There've been a number of studies now where people are actually trying to provide drug levels and see how just providing those levels improves outcomes, or providing support groups, basically saying, how do we move the needle here in a meaningful way that helps people? Um, and the cost of not doing this, the cost of people switching to other regimens or developing drug resistance is very, very significant, right? And as I've mentioned, HIV affects people in places where there's already socioeconomic other marginalization factors. So if we can do this without people having to needlessly switch to regimens, that then if they're still not adherent, you might actually still have to switch them away from later. There are huge costs to what we're currently doing. So there's a growing interest in integrating antiretroviral drug level monitoring into HIV prevention and care. And when we started, we said, what drug do we even measure? So we went back to WHO guidelines, and one drug that came up everywhere was this drug TDF. I will mention that if after this talk you go and look up different HIV drugs, just be prepared to start getting HIV medication ads all the time. That is all I get now on whatever platform I'm on. And the ads all follow the exact same formula. But yes, I get HIV ads all the time. People have tried to measure this drug. We're not the first to think about it. Some people have made lateral flow tests, which would be wonderfully convenient and fast, right? But they are susceptible to something that we call the white coat adherence. And white coat adherence comes about because the drug that we're measuring, this tenofovir drug, that's sort of the drug we care about in TDF, has a 15-hour half-life in plasma and urine. And what that means is it spikes every day when you take it. If you stop taking it for a while and then you take it again, it will spike again and then it goes down. And people have figured out in some of these studies for adherence that if you take it the day before, then it will always show up well. And we actually find that once you introduce a lateral flow test, sometimes people perform better, but in the long run, it actually might just go back to the mean because people figure out how to game the test. So we know, this is the one sort of chemistry-ish slide that I'm going to show. We know that tenofovir gets metabolized intracellularly into its active form that's called tenofovir diphosphate. And tenofovir diphosphate actually accumulates in red blood cells, and it accumulates with a 17-day half-life, which means that even if you stop taking it, the drug level slowly decreases and doesn't just suddenly drop off. And what that means is that it can give you a window of how somebody's doing over a 1 to 3 month window. And this is work that my collaborator, Pete Anderson, who's done a lot of the studies for measuring HIV drugs in clinical trials, found out. And so this allows you to get sort of a window. It's a bit like if somebody has diabetes, you want to know their blood sugar, and that tells you how they're doing right now. But really, you want to know their hemoglobin A1C, which tells you how they're doing over the long term. So tenofovir diphosphate, this active form, really is what we care about. Another really cool thing about tenofovir diphosphate is it actually really weirdly builds up in red blood cells. Normally, HIV affects your immune cells, as I mentioned, but there's a paper from 2007 where they just randomly found that tenofovir diphosphate builds up in red blood cells. It's not by design, but the nice thing is we have a lot of red blood cells, which is why our blood is red. And red blood cells are super wimpy. So if you put them in water, they will swell and burst. Put them in anything isotonic, they will burst and release their contents. So again, tenofovir diphosphate gives us this really long half-life for long-term adherence monitoring. It also is very easy to access because it's in a lot of red blood cells. So again, you can see how this is a really good diagnostic problem for us. The challenge is we don't have good immunoassays. We don't have lateral flow assays that work well for tenofovir diphosphate. It's so similar to tenofovir that we don't have the specificity with lateral flow. Not yet. People are working on it, but we don't have that right now. And so the gold standard is to do mass spec. Mass spec is wonderfully sensitive. It's very specific. It's very quantitative. It can distinguish tenofovir from tenofovir diphosphate. But as this image shows, it's centralized and bulky. You need highly trained people. It's expensive. There's something like 4 or 5 labs around the world that are accredited to this measurement. There's a long queue, and it's something like $200 a test, which again, for a disease that affects people in low resource settings is a non-starter. So when I came to the University of Washington in 2018, my mandate, I was a postdoc working with Paul Drain in global health and Jonathan Posner in mechanical engineering. And our goal as a team at the time was, can we measure tenofovir diphosphate as a proxy of long-term HIV medication adherence at the point of care? We looked at tenofovir diphosphate and its mechanism of action, and I sometimes use this slide as a Where's Waldo slide. What is different between tenofovir diphosphate and deoxyadenosine triphosphate, basically your A building block in DNA? Some of you might have seen it, and it's basically that you have this sugar ring in DATP, but you have this terminal methyl group in tenofovir diphosphate. And what that means is that tenofovir diphosphate terminates DNA synthesis. So when HIV reverse transcriptase enzyme, which is the same RT actually in a lot of your RT-qPCR assays, we just got better engineered versions of it. But when that RT takes a viral RNA template, it can also take whatever DNA template you give it and tries to make DNA from it. It'll start putting your A, T, C, G, like in your classic molecular biology. If it encounters tenofovir diphosphate or any other drug in that class, it will put it in, but that terminal methyl group means that it's kind of like a really bad Lego brick where you've shaved off one end. And what you've done is you can put that Lego brick in, but you can never add anything back in. It's like a terminal piece, right? So what we've done is we've created this class of drugs that actually came from cancer research that can stop DNA synthesis and can stop HIV reverse transcriptase DNA synthesis. I was working with a postdoc at the time who was at Harvard Medical School, but he's now faculty at Carnegie Mellon, Dr. Darren Sevenler. And the idea we had was, can we use this DNA chain termination ability of tenofovir diphosphate to measure its concentration? Can we take blood, add it to an RT reaction, just the first part of your RT-qPCR, and then see what we get? And so we came up, because we're engineers, we called it restrict reverse transcriptase chain termination. And when you have a lot of the drug, you can't make DNA. If you don't have much drug, you can make lots and lots of DNA. You can add a little intercalating dye that gives you a signal, and you get this sort of classic sigmoidal enzyme inhibition curve. The workflow is actually pretty simple, again, because of the RT step of an RT-qPCR. You collect blood, you dilute the blood, burst your red blood cells, add it to your RT reaction, incubate at body temperature for 30 minutes, add a fluorescent dye at the end to tell you how much DNA you had. If you had a lot of drug, you don't get much signal. If you didn't have much drug, you make lots of DNA and get lots and lots of signal. We calibrated this just by adding tenofovir diphosphate into blood at known concentrations from what we found from clinical trials with LCMS. And then we use these as like a priori thresholds that we could then use to assess clinical samples. And what we found was we went and did a pilot evaluation with folks at the Center for AIDS Research here in Seattle. And the research coordinators were wonderful. They would consent patients. I would go to them every day, bring a little cooler, get on the bus with blood, come back to the lab and test it. And those were really, really fun days. And they were super supportive. And that's one of the things that makes this a good place to work on this. We tested 18 samples. Most of them actually didn't have drug in their system. But on the left, here's a graph where it's looking at people above or below the threshold that corresponds to 4 doses a week. So this is the threshold where you don't have to really worry if there's a risk of HIV infection, if somebody's trying to prevent HIV. And we saw that, by and large, you're able to distinguish most of the people above the threshold, but one sort of fell through here. And then if you use a more stringent threshold of the 7 doses a week, it was a little bit better. We were excited, but I was also a little bit disappointed by how much spread we saw among this level. Ideally, you almost wanted to like make these as polar opposites as you can. So one of the things that we worked on was we said, can we improve the performance of this assay to really distinguish no drug versus drug? And so one of the things we did was not just diluting blood, but we found a collaborator at Harvard Medical School, Dr. Becca Sandlin, and then Ben Sullivan, who was a PhD student at the time, but now is a scientist at GH Labs. One of the things that he found was that heat in the blood allowed us to get very, very similar performance to who are using buffer only, because heat in the blood essentially cooks out a lot of the proteins, so hemoglobin, antibodies that can non-specifically bind to our HIV enzymes and mess with the performance of our assay. So we heated the blood, things got much cleaner. And then Cosette Craig, who's a PhD student in mechanical engineering in my lab, went and did a validation with dried blood spots from a clinical study that was done in Thailand with 72 clinical samples. X-axis here is mass spec measurements. Y-axis here was our restrict assay. We actually saw a really good correlation between the two. So we were like, okay, great. We're in business. Something is happening. I'm going to sort of start rounding off a little bit and closing off by telling you some of what we're working on now. So what are we thinking about? So in 2021, there was this announcement that the US FDA had approved injectable medications to treat HIV. And in my mind, I was like, well, this solves the problem. You don't have to take your meds every day. You just have to get an injection every month or every other month. Surely that solves the problem. And because technology is rarely a magic bullet, people very quickly started to point out, rightfully so, that if you look on the y-axis, this is drug concentration, x-axis is the time since injection. Each line here is a different person in this clinical study. And then this middle line is the PAIC90, roughly like how much do you need to inhibit 90% of virus in a sample. What you find is some people can have drug in their system for up to close to 5 years. Some people, it drops off within a year. How many times do you think about the injection you got 5 years ago? And the reason why this is a little bit scary is if people drop below this protective level, a little bit of drug is actually the perfect condition to breed drug resistance. And once you get drug resistance to a drug in a particular class, it can start to spread. So we're finding that new medications can help, for example, help people not have to take pills every day, but it might actually introduce new problems like this risk of drug resistance. So we went and said, can we identify when people start to enter this long pharmacokinetic tail, as it's called, to identify the risk of treatment failure and drug resistance? And another way of thinking about this is we often give medications like everybody processes it the same way, but we know that you can't use a one-size-fits-all model, right? And there are many different reasons why antiretroviral drug levels may vary. We focused a lot on adherence, but you could also have comorbidities like kidney issues. You could also have drug-drug interactions. You could have genetic variability, special populations, resistance. So the French government has actually released guidelines that recommend therapeutic drug monitoring of these long-acting injectable medications for a variety of modalities. And Cara Brainerd, who's a PhD student in my lab, was actually just graduated and just defended her thesis. She showed that we can measure rilpivirine, which is a long-acting reverse transcriptase inhibitor, and we can measure it around this threshold that the French government recommends. Another thing that we've been doing with my colleagues, my next door neighbor in the bioengineering department, Barry Lutz, his lab during the COVID pandemic made this little portable reader that they call Harmony that can do RT lamp isothermal DNA amplification assays. We said, can we use that and compare it with a plate reader in our lab? It's a $300 instrument. It's about the size of an apple. And what we found is that we got pretty good results. The other things we've been doing are how do we move this test out of our lab and into people's hands, right? So I showed you this workflow that's relatively simple, but some of the things we don't like about it, we have to add this dye at the very end because the dye itself actually stops your DNA synthesis. So is there a way we can make that simpler? This requires very precise timing as well, because somebody has to add it right at the 30-minute mark. So you don't want somebody to be sitting there being like, is it 30 minutes yet? Do I have to add it now? There's still some liquid handling steps, and you still need fluorescence readout. So where we're going with this is, can we automate this with some of the microfluidics I talked about earlier? And could we go to a lateral flow readout where somebody can get a result regardless of an instrument? That would be the dream. We've got this feedback from focus groups, clinicians, patient advocates. We've been working with Barry's lab a little bit more on this. They've been using CRISPR-Cas enzymes, and this is similar to some of the work that you saw with Sherlock and a lot of Detector, a lot of the other CRISPR-based diagnostics, where you're basically using a CRISPR-Cas enzyme to look for the DNA that you've made, and you can add that in at the beginning. And unlike those intercalating dyes, the Cas enzymes can start to give you results in real time. So my PhD student in my lab actually showed that you can get these real-time results just by replacing your intercalating dye with Cas enzymes. And you can even get some really cool specificity because now you can start to work in the background of DNA. You can work in white blood cells and not have to worry about cross-reactivity because you have a specific readout with your enzyme. The other thing we've been doing, Catherine, who's an undergrad in bioengineering, and Megan, who's a postdoc in my lab, have been looking at, can we get lateral flow readout with CRISPR enzymes? In the case where your RT enzyme is inhibited by your drug of interest, then what happens is the CRISPR enzyme does not cleave these reporters. You have these intact reporters that you can capture on a lateral flow strip and you get these two lines. But if HIV RT is not inhibited, meaning the person did not take enough drug, then you can make a lot of DNA, CRISPR enzyme is activated, it cleaves everything, and then you get sort of a different signal readout. So we're just repurposing something that's been done in the CRISPR literature, but using it for this very specific application that we have in mind. Carrie Lean, who's a recently graduated mechanical engineer, has shown that we can actually do a proof of concept with lateral flow readout and start to distinguish between somebody at the 2-dose-a-week level and the 7-dose-a-week level. And this is our lateral flow strips that we tested and just quantified on a flatbed scanner. So we're very excited about these results. We've also started doing some initial integration of these lateral flow strips into capillary-driven microfluidics. And this is just a time-lapse video that Carrie made in the lab where she's adding our assay reagents to the microfluidic chip and letting it control how long the reaction takes. And we've done some very, very quick work with fluorescence readout by taking samples from a chip versus doing this on a tube and measuring the results on a plate reader. So we're very excited about this direction in our lab. And I'm going to close off by telling you the thing I am most excited about. And I think is sort of the next big problem in this space that we're working on. And I'm going back to this flowchart for a very specific reason. We focused on this adherence point in the middle, but some of the parts that we haven't focused on yet, these regimen switches, these ideas of you switch regimens because you believe somebody has developed drug resistance. In fact, drug resistance screening should happen. And if the person were in Seattle and they had access to really good healthcare, it would happen, but it would probably cost the healthcare system $500. In most contexts where HIV is endemic, in low and middle income countries, resistance screening doesn't always happen because it's either prohibitively expensive or we just don't have the instruments to do it. And even if we do have the instruments, it's often done with sequencing and genotyping, where it's not often done with genotyping, where the mutations that happen can make those not that accurate. The other thing that's really fascinating in this space is that the WHO actually recommends pretreatment drug resistance screening, but they don't put it in their workflow because it's just not practical. So if we could figure out a way to do drug resistance screening, that would be very, very impactful, arguably more impactful than the medication monitoring that we're doing. So this is what Megan has been thinking about a lot. Can we develop an enzyme activity assay that can capture, instead of capturing drug now, can we actually capture HIV RT enzyme from a blood sample and then do the same RT activity assay on it and expose it to different drugs, like a phenotypic drug resistance assay? So it's something we're working on. It's a harder problem because you can't just heat things and cook things, and you have to be very, very precise in capturing just the enzyme that you care about and not getting off-target effects. But something that I hope that maybe in a few years we can talk about more with this community. And this is also a place where, because of the capture and sort of sample purification, perhaps concentration required, there might be more need, arguably, for microfluidics. So I'm going to close with some lessons learned and sort of path forward. I hope I've convinced you that by immersing ourselves in the problem and developing these strong partnerships, we can uncover unique solutions that don't necessarily leverage the strengths that we had going in, but allows us to build new strengths and bring our engineering mindset and approach to problems where there's a really big clinical need. I hope I've convinced you that this restrict assay can measure clinically relevant drug levels, that it correlates with mass spec. I hope I've also convinced you that there's potential to integrate this into point of care formats and expand to other challenging problems. And I just kind of want to end by going back to this scenario, right, with like the clinician and the patient, because this is really what drives and what anchors us. At the end of the day, I don't really care what technology we use, as long as we get something that we can get into people's hands and make their lives better. I'm happy to take your questions. Feel free to reach out if you have questions. And I also wanted to actually do a little plug because a lot of the science community has moved over to Blue Sky. I actually made a little sort of starter pack for people who do microfluidics and microfabrication. So if you're interested in that space or want to follow people who do this kind of work, happy to add you. Just ping me and reach out to me. And thank you for your attention and the invitation.